So, changing a little bit the topic into LASIK screening to prevent keratectasia after LASIK. What's your routine, and could you summarize your gold standard for doing this screening for patients for LASIK?
You mean to avoid or to prevent keratectasia? I mean, I'm pretty much coming along with this ectasia score from Randleman in Emory, using parameters like age and thickness of the cornea and myopia correction, the degree of myopia correction. However, what I'm really missing in that ectasia score of Randleman of the Atlanta group is that that they never looked at the posterior surface of the cornea. We all know that the epithelium of the cornea is leveling out irregularities. Dan Ranstein showed very nice maps of the epithelial thickness in keratoconus, and it turns out that over the peak of a keratoconus, the epithelium can be as thin as 25 microns, and at the fundus, at the basis of the cone, it's then 70-75 microns thick. And that means that we are missing 5 to 10 diopters in that range by just leveling out effect of the epithelium. So it's quite natural to look at the posterior surface of the cornea, where the endothelium cannot level anything out, and so that posterior float is for me a crucial thing. If I have a posterior float seen in the pentacam with a spherical approximation within 8 millimeters of more than 15 microns, I just leave my hands off. Period.
Even no PRK?
Oh, the PRK has to be discussed with the patient, and that is very much depending on the state of the patient. I mean, if it's a young lady, I rather would do the cross-linking doing at the same time with the surface ablation. If it's a guy 28 years old, or say 38 years old, asking for 5 diopters of myopia correction, I would not hesitate to do a surface ablation without cross-linking, of course.
Great. And the last question goes, I cannot, we are in a cross-linking and keratoconus, that's all about it, but in going to refractive surgery, what do you think is the future of the refractive surgery on the cornea?
Oh, I truly believe that on a long-term run, we will have only one laser doing the job. Most probably we will have only a femtosecond laser, which will not work in the infrared right now, but most probably will have a wavelength in the bluish range, because the femtosecond laser in that wavelength range will be able to have a precision of less than a micron regarding cuts and reshaping of the cornea. And therefore, I believe on a long-term run, we will get rid of the excimer lasers and have only femtosecond lasers to do the job.
That's excellent. Thank you very much.
You're welcome.
So it's a pleasure to have you here.
Oh, come on, the pleasure is quite on my side. Coming to Brazil and seeing friends and being accepted and enjoying the hospitality.
Okay, thank you very much.
Thank you very much indeed too.